The standard sleep study that we do at Aiken Neuroscience is a nocturnal polysomnogram, which simply means that we look at a whole ton of data through the course of the night. For some people, like our technicians who sleep during the day, we have the availability to perform these tests during the day. And there are other tests, especially those mandated by the DOT, that professional drivers and pilots, for instance, have to go through if they meet certain criteria. We're able to do those, and we do those on a regular basis. The study, from beginning to end, I'll tell you what I tell the patients. Initially, we look at the whole picture of what's going on with the patient. We have audio and video so we can see what's going on and understand and hear what they're doing. And we match that to all the data that we capture on the computer, which is a lot of data. You'll see that in a few moments. We have many wires on their head, which will let us know exactly how many, or when the patient sleeps, is awake, and how often they break out of their normal cycle of sleep. To make sense of what happens there, we look at many different things through the course of their body. We observe EKG through the course of the night. We have belts that let us know the rate and effort that they breathe with, and a series of flow meters, which is the most annoying part of the whole study. I tell this to everyone from the beginning, try to take away the discomfort if I can. But the flow meter will let me know how much air actually passes in and out. We'll use a snore mic, an oxygen probe on their finger, and a set of wires go into their legs to let us know if their legs are kicking while they're sleeping. That's the basic study. If the physician feels that there's potential for seizure activity with the patient, we will do an expanded grouping of wires on their heads to isolate potential seizure activity and be able to map it better. And then there are all the other extensions to the application on the body. If there are particular problems that the physician chooses to look at where there's an indication that there's a problem related. Now, if the patient has obstructive sleep apnea, we're able to detect a certain amount of disruption in their airflow through the first 2 hours of the study, of their sleep rather, then we will treat the patient that first night. And that involves applying CPAP, or continuous positive airway pressure. But if not, we'll observe them through the whole course of the night. We have a very rapid turnaround. The physician will have the study for observation typically the next morning, if not the day after, and we'll be able to get back to the referring physician or schedule a follow-up appointment if necessary. If a patient is being treated and comes in for CPAP therapy, and I'll talk about CPAP for a moment, as I said before, it stands for continuous positive airway pressure, and what that simply means is we're going to apply a certain amount of pressure via a mask, and there are many different types of masks to be able to get as comfortable as possible with the many different types of faces that we have. And all we want to do with CPAP is create a pocket of pressure that the patient breathes from. It's not forcing any air into the patient, but rather just having that potential pressure there, so when they inhale, it goes in easily, keeps the airway open. The big trick there, for me, is to limit that air pressure as much as possible so that the patient is able to breathe out against it. Once we get the patient to that point where they're breathing in and out easily, they fall into a very beautiful place. They're able to appreciate levels of sleep that they haven't enjoyed in many cases for decades. And the results that we get from that are outstanding. The blood pressure will reduce because the heart rate does not spike up and down as related to respiratory events. Oxygen levels are maintained. Different sleep stages are gone through as is normal. Patient wakes up happy in the morning. It's a beautiful thing.